Hello everyone, my name is Elizabeth ZinantiE, and today in GrandRounds I will be presenting breast cancer. An outline for today's presentation includes objectives, an introduction to our case study, breast cancer background, an etiology and epidemiology of breast cancer, the pathophysiology of breast cancer, the role of genetics in influencing breast cancer, our patient's presentation, any differential diagnoses and also the workups to rule out those diagnoses, and disease management, and this includes pharmacological interventions as well as non-pharmacological interventions. The objectives for today's presentation are to prepare pre-licensure nursing students at the associate degree level in caring for patients who do have a breast cancer diagnosis. And after this presentation, the learner will be able to describe the disease process of breast cancer, identify modifiable and non-modifiable risk factors for breast cancer, and also discuss treatment options for breast cancer. Mrs. Blake is new to the area and seeking out a new primary care physician, which brings her to our clinic today for her initial appointment. Her vital signs are stable, with a blood pressure of 119/65, a heart rate of 78, a respiratory rate of 18, an SpO2 of 99% on room air, and a temperature of 98.1 degrees Fahrenheit. While collecting her medical history, she reveals that her family has an extensive cancer history. Mrs. Blake's maternal grandmother died of breast cancer at age 45, her mother died of breast cancer at age 51, and her sister is still living but has had breast cancer. Additionally, all three of her maternal aunts have died of cancer, two from breast cancer and the other of ovarian cancer. She also has two living cousins who have had breast cancer. Breast cancer definition and background. Breast cancer is a malignant alteration of normal breast tissue and is the most common malignancy diagnosed in women worldwide. Breast cancer can be classified as carcinoma in situ or invasive breast cancer, depending on if the malignancy has spread beyond the breast's basement membrane. The exact causes are largely unknown, however, aging and family history greatly increases risks. There are also very strong proven associations with gene mutations, such as those with the BRCA1 and BRCA2 genes. In addition to aging and family history, lifestyle factors have a great influence on developing breast cancer, such as smoking and sedentary lifestyle. The epidemiology of breast cancer. 95% of new cases affect women over 40 years of age. The average lifetime risk for a woman to develop breast cancer is approximately 12%, but this risk can be up to 3 times greater in women who have a family history of breast cancer or ovarian cancer. Breast cancer is the second highest cancer to cause death in women, it's second only to lung cancer. In addition, the American Cancer Society predicts that in 2019, there will be 268,600 new cases of invasive breast cancer, 62,930 new cases of carcinoma in situ, and 41,760 deaths related to breast cancer. The pathophysiology of breast cancer. Breast cancer arises from normal cells who have had their DNA altered. The cause of this alteration is multifaceted, with genetics and environmental influences playing instrumental roles. Most breast cancers are adenocarcinomas that develop from the ductal and lobular epithelium. The most common types of breast cancer are invasive ductal carcinoma and invasive lobular carcinoma. However, there are many forms of breast cancer. Because breast cancer is a diverse group of tumors, this has led to complications and difficulties for treatment options. There are 4 models of breast cancer carcinogenesis. There is the gene addiction model, the phenotype plasticity model, the cancer stem cell model, and also the hormonal outcomes model. The gene addiction model states that genes are primary influences for cancer development, whether the genes are oncogenes, which can initiate cancer growth, or non-oncogenes, which are genes that do not directly cause cancer cell development, but their activation or inactivation may facilitate cancer growth. The phenotype plasticity is a naturally occurring process in development that gets overtaken as cancer progresses, and it bestows cancer cells with some of their trademark qualities. The cancer stem cell model holds that cancer cells may move into nearby tissues as cohesive clusters as opposed to random scattering. And the hormonal outcomes model is the view that hormonal changes can perpetuate cancer growth by affecting cells of the breast tissue as well as cells of the immune system. While there are many different types of breast cancer can be categorized into two categories. We have our carcinoma in situ, and then we also have our invasive breast cancer. Carcinoma in situ can further be broken down into two types, the ductal carcinoma in situ and lobular carcinoma in situ. Ductal carcinoma in situ is confined to the breast ducts and the lobules, and it accounts for 84% of all in situ disease. Histologically speaking, the cells within ductal carcinoma in situ are not uniform, which means if you looked at them on a slide, or if you decided to test them for their genetic properties, each cell would be different. Ductal carcinoma in situ should be considered a risk factor for invasive breast cancer, but it may not need treatment if it is found at a low or an intermediate grade. Lobular carcinoma in situ arises from a breast terminal duct lobular unit. In contrast to ductal carcinoma in situ, the cells involved with lobular carcinoma in situ look much more uniform, even though they may be more malignant. The lobular carcinoma in situ frequently occurs bilaterally, and up to 35% will develop into invasive carcinoma. Now, invasive breast cancer occurs when there's a malignancy which breaches the breast basement tissue and it begins to invade surrounding tissue. It may be localized to within the breast, or it may spread to other body parts, in which case we call it metastatic breast cancer. The role of genetics in breast cancer. Breast cancer risk has been proven to be greater in men and women who have mutations in their BRCA1 or BRCA2 genes. Other genes that have been linked to breast cancer, though to a much lesser extent than the BRCA genes, include the ATM gene, the TP53 gene, the CHEK2 gene, the PTEN gene, CDH1 gene, the STK11 gene, and the PALB2 gene. Genetic mutations lead to the development of cancer by allowing cancer to avoid our body's typical surveillance. In the case of BRCA1 and BRCA2 genes, they are known as tumor suppression genes, and when they have mutations, it allows for cancer to grow uncontrollably. Upon physical examination, Mrs. Blake is alert and oriented ×4 with no complaints of pain. Her skin is intact, appropriate in color, temperature, and in turgor. Her lungs are clear to auscultation. She has a normal sinus rhythm on the monitor, as well as a regular S1 and S2 upon auscultation. She has no GI complaints, as well as no GU complaints. As Mrs. Blake's family history is extensive for breast cancer, should a mass be found, the differential diagnoses would include mastitis, fibroadenoma, cellulitis, abscess, as well as pregnancy. These conditions can lead to a change in the breast tissue. Mrs. Blake's physical examination was unremarkable at this time, but given her history, screening includes a yearly mammogram with an MRI, a clinical breast exam whenever she is in the office, monthly self-breast exams. She did decide to pursue genetic testing and she came back positive for the BRCA1 gene, which means that we need to have a much higher level of surveillance on her. Diagnostic procedures, if a mass should develop, will include a follow-up mammogram with an MRI, potentially an ultrasound of the breast or the nipple or the axilla area, or a core needle biopsy to rule out malignancy. Now, as a side note, they do say now self-breast exams are no longer widely recommended, but I do personally have a hard time discouraging our patients from being actively involved in their care and knowing what's normal for their body. One treatment option for Mrs. Blake includes tamoxifen. It is an anti-neoplastic agent and also a selective estrogen receptor modulator. It works by competing with estrogen for the estrogen receptors of cancer cells, and this binding prevents malignant growth. It is used as prophylactic therapy for breast cancer in high-risk women. It is also used as adjuvant and neoadjuvant therapy for breast cancer, which means that it helps decrease the size of the tumor, and it is used in metastatic breast cancer. Side effects include hot flashes, irregular periods, and also vaginal discharge. Adverse effects include Stevens-Johnson syndrome, pulmonary embolism, and thrombolytic disorders. Contraindications include a history of DVT or PE, currently using warfarin, and also a previous hypersensitivity to tamoxifen. Drug interactions include warfarin because tamoxifen will cause an increased risk of bleeding. St. John's wort should not be used with tamoxifen because it will decrease tamoxifen's effectiveness. If you look in your drug book, there are multiple contraindications for tamoxifen, but a lot of them come down to they prolong the QT interval on your EKG, or they either decrease or increase the risk of tamoxifen. So we need to really be mindful before we give any medication to ensure that there's not a interaction there. Nursing considerations for tamoxifen administration, you need to make sure that this patient is not pregnant, just to make sure that, because this is very high risk to the fetus. You need to regularly monitor our patient's breast exam and any of her mammograms. We need to monitor her lab levels. We need to help make sure we educate our patients to use 2 types of contraceptives in order to prevent pregnancy while she's receiving tamoxifen. And then also we need to make sure she doesn't get pregnant for up to 2 months after she's stopped taking tamoxifen. One other thing we need to make sure we do is to educate our patient on the signs and symptoms of a DVT or PE or stroke to make sure that they get medical treatment as soon as possible. Another treatment option for Mrs. Blake includes raloxifene, which is a selective estrogen receptor modulator. It works by selectively activating and inhibiting various estrogen pathways by binding to specific estrogen receptors found on cells. It is used as prophylactic therapy for breast cancer in postmenopausal women, treatment of invasive breast cancer, and it is also used for prevention and treatment of osteoporosis. Side effects include hot flashes and leg cramping. Adverse effects include pulmonary embolism, cerebrovascular accident, and thromboembolic disorder. Contraindications to raloxifene's use include pregnancy, a woman currently breastfeeding, a history of DVT or PE. Drug interactions include ospemifene because it is also a selective estrogen receptor modulator, and using raloxifene alongside it can increase the toxic effects of ospemifene. Warfarin and raloxifene should not be used together because you may lose their therapeutic anticoagulation. Cholestyramine and the raloxifene should not be used together because it may decrease raloxifene absorption. Nursing considerations is that we need to make sure our patients are not pregnant prior to starting raloxifene, so we need to administer a pregnancy test. We also need to make sure that they're getting regular eye exams because you can have a retinal vein thrombosis, and we need to teach them about the signs and symptoms of that. We need to regularly monitor our patients' mammography and their breast exams. We also need to educate our patients to use 2 different types of contraceptives to prevent pregnancy during treatment, and they need to continue using 2 different types of birth control at least 2 months after therapy is ended. And we need to teach them on the signs and symptoms of a DVT, a PE, and a stroke. Non-pharmacological management for Mrs. Blake could include a bilateral mastectomy with or without a total hysterectomy. I know many people hear that and they think that it sounds extreme, but I have a friend who had her mother pass away from ovarian cancer, and when she was done with having her children, she just went to her doctor and said, I don't want anything that increases my risk because I don't want to put my kids through what I went through with my mother. So it sounds extreme, but for many people, it's a very, very real and option, and many people consider it their best option. One of the other things we need to consider with Mrs. Blake is that we need to attend to her mental health and help reduce her stress and anxiety levels, given that she's BRCA1 positive. So meditation and yoga are absolutely great options for stress relief. Some people enjoy using aromatherapy Doing regular exercise is also a good intervention. Journaling. We just need to make sure that we're attending to the emotional and the mental health side of this diagnosis. Nursing considerations for Mrs. Blake include the implications of her genetic testing. Because he did test BRCA1 positive, we need to make sure that we're asking appropriate questions to see if she's having any alterations in her mental health. She could be having anxiety or fear or depression because she's tested positive. And this is just a good rule of thumb whenever you have patients who do decide to undergo genetic testing, regardless of the results, there's often a struggle. You have patients who, if they test negative, they may develop feelings of guilt or anxiety if, say, their family member did test positive and they had a cancer diagnosis from it. For those who test positive for a genetic mutation, they may be angry. They may feel guilty if they have children, wondering if they passed it down to their children. And they may be fearful for when they might develop cancer. So, as nurses, we need to be mindful that we address any of those feelings because it's completely appropriate. Needed diagnoses for Mrs. Blake include a readiness for enhanced knowledge related to breast cancer as evidenced by seeking out a new primary care physician involvement, and also risk for disturbed personal identity as evidenced by testing positive for the BRCA1 gene. Prevention options for Mrs. Blake include chemoprevention with tamoxifen, and we also discussed surgical options of a bilateral mastectomy with hysterectomy. Lifestyle modifications that we chose to focus in for her was increasing her physical activity and also improving her diet. Mrs. Blake is currently a non-smoker and does not regularly drink alcohol, so those lifestyle aspects do not need to be addressed. But physical activity does need to be addressed for her because she lives a fairly sedentary lifestyle, and regular exercise is one of the proven modifications that can decrease your risk for breast cancer. Additionally, we wanted to focus on her diet because she largely eats out, so we want to focus on increasing her fruit and vegetable intake, as well as increasing her good fats such as olive oil and fish, because these can reduce your risk for breast cancer. At her follow-up visit in the clinic, Mrs. Blake decides to begin tamoxifen therapy for 5 years. She's scheduled for her yearly mammogram with an MRI in 2 weeks, and she shares that she's going to counseling through her job in order to work through some of the emotions related to being positive for the BRCA1 gene. Additionally, she has sought out a local support group for those who are positive for the BRCA1 and the BRCA2 genes. Reflection number 1. Discuss new options for breast cancer or breast cancer prevention that are currently being researched. Reflection number 2. Describe at least one controversial therapy for breast cancer or breast cancer prevention. Reflection number 3. Explore an ethical dilemma related to genetic testing. And here are my references. Thank you for listening and have a great day.